Is lumbar puncture and anatomical basis of lesions of the vertebral column. So in this we discuss the competency, that is lumbar puncture, site, direction of the needle, structure pierced during the lumbar puncture. Lumbar puncture needle pierces in order, that is starting from skin, subcutaneous tissue, supraspinous ligament, interspinous ligament, ligament of flavum, epidural space containing intervertebral venous plexus, dura, arachnoid, and finally the subarachnoid space. Intercostal or tough line. The most important bony landmark is L4 spinous process. It is located at the intersection of the intercostal or tough line, that is the line between the top of the iliac crest and the lumbar spine midline. Distance from the skin to the epidural space is 45 to 55 millimeters and the dura mater thickness can be 7 millimeters beyond the depth. Lumbar puncture or spinal tap. It is the insertion of the needle into subarachnoid space in the spinal canal. The easiest method of performing a spinal puncture is to have the patient sitting on a stool with the arms and head resting on the table. With the patient in this position, it is possible to keep the needle exactly in the midline. This method is used if the sole purpose of the puncture is to obtain cerebrospinal fluid. To know the intracranial pressure, puncture is done with the patient lying on his side, with the knees drawn up close to the head. External occipital protuberance of the skull should be in the horizontal plane with the lumbar spine. Procedure. The usual site of is the fourth lumbar interspace, which is approximately in the same transverse plane as the crest of the ilium. The interspace is firmly palpated with the thumb. At this point, the skin is anesthetized with about 2 cc of lignocaine. 22 gauge needle are satisfactory for spinal anesthesia. 18 gauge needle is used if information is desired regarding intracranial pressure and patency of the spinal subarachnoid space. The needle is introduced into the midline. If the bony resistance is encountered during the insertion, the needle is withdrawn 1 or 2 centimeters and reintroduced in a modified direction. As the spinal canal is approached, the needle is moved forward 1 centimeter or less at a time and the stylet is removed. When the flow of spinal fluid is obtained, the stylet is immediately reinserted. If the purpose of lumbar puncture is for determining the intracranial pressure, the sterile water manometer for the purpose is readied. The stylet is withdrawn and the manometer is attached. After the intracranial pressure has been determined, the manometer is removed. About 6 cc of cerebrospinal fluid is collected in several sterile bottles for laboratory studies. When the procedure is complete, the needle is removed and a sterile piece of gauze is applied to the site and fastened with adhesive tape. Immediately following the procedure, patient may be placed in the dorsal recumbent position, preferably with a pillow under his head. Some patients may complain of headache following lumbar puncture. It is generally believed that the headache is due to the tear of the dura mater, which allows the seepage of small amounts of CSF. It has been shown that headaches are rare and at least not severe if patients are kept in bed without a pillow immediately. Then we go to explaining the anatomical basis of scoliosis, lordosis, prolapsed disc, spondylolisthesis and spina bifida. Scoliosis. Scoliosis is a structural three-dimensional deformity of the spine. It is related to growth. Non-structural deformity can be caused by lower limb disorders resulting in limb length discrepancy, such as hip dysplasia, limb deficiency syndromes, and herniated discs in the older children. Scoliosis can also be classified by cause into idiopathic and secondary. Idiopathic scoliosis is further classified into infantile, juvenile, and adolescent types. Scoliosis can also be secondary to congenital disorders, neuromuscular conditions, tumors, trauma, or syndromic. A scoliosis has a primary curvature and a secondary curvature. Each curve has a convex side and concave side. The primary curve is usually stiffer. The curved side is classified according to the location of the apical vertebra in the coronal plane as cervical, thoracic, or lumbar. Junctional curve. Cervicothoracic, thoracolumbar, or lumbosacral has apical vertebra at the interface between these two areas. Apical vertebra is the most rotated vertebra in the curve. End vertebra is the most cephalad, and caudal vertebra whose superior and inferior surfaces respectively tilt maximally towards the concavity of the curve. Curve size is assessed by the measurements of Cobb's angle, which is usually described in the direction of the concavity. This is done by drawing lines perpendicular to the transverse axis of the upper and lower end vertebrae, where these lines intersect in the Cobb's angle. Previously, this was done using a device called as scobometer, which can now be done with computer software. Lordosis. Lordosis is the inward ventral curvature of the lumbar spine. It is formed by the wedging of the lumbar vertebral bodies and the intervertebral discs. Lumbar lordosis is influenced by the shape of the vertebral bodies and the shape of the intervertebral discs, because each account for nearly 50% of the variability seen in the lordotic angles of the adults. Each of the 5 lumbar segments, vertebral body and adjacent disc, contribute to the lordosis. The last lumbar segment, L5, contributes 40% to the overall lordosis. First segment, L1, contributes 5%. Prolapse disc. Intervertebral discs comprise a gelatinous core, that is the nucleus pulposus, with a surrounding tough ring, that is annulus fibrosus. An increase in the internal pressure of the disc creates stretch forces on the annulus and may cause annulus to tear. The nucleus then herniates through the annular tear into the spinal canal, where it may compress nerve roots. Disc prolapse is the most common at L4 or L5, L4 and L5, or L5 and S1, because these levels carry the largest axial load and are very mobile. Nucleus degenerates with increasing age. Degenerating disc loses height. As a consequence of disc degeneration and reduced spinal mobility, lumbar disc prolapses occur in adults younger than 45 years and are rare in elderly. Disc prolapse in younger occurs primarily at L5S1 and L4 and L5. Spondylolisthesis is common degenerative spinal disease. It is described as a condition in which a vertebral body compared to the vertebral body beneath it shifts forward with intact neural arch. It commonly occurs at the 4th and 5th lumbar vertebrae and accounts for more than 75% of the cases of spondylolisthesis. Spondylolisthesis is defined as anterior or posterior migration or slippage of one vertebra in relation to the next caudal vertebra. It most commonly occurs in the lumbar spine and is considered to be due to spondylolysis or degeneration. Hereditary, traumatic, mechanical, or hormonal factors may also play an important role in the process. It is known that women are approximately 3 times more likely to be affected by spondylolysis than the men. Spondylolysis is usually asymptomatic. It can progress to spinal stenosis and results in neurogenic symptoms such as leg pain, numbness, and weakness. Spina bifida. Spina bifida, otherwise referred to as neural tube defect, it is a birth defect. Spina bifida is an incomplete closure of the neural tube anywhere along the spine. Spina bifida cases fall into 2 categories. Spina bifida aperta, that is open type, and spina bifida occulta, that is hidden type. Spina bifida aperta encompasses myelomeningocele and meningocele. Protrusions of the spinal nerve roots and membrane layers that cover the spinal cord and brain are referred to as myelomeningocele. About 10 to 20% of myelomeningocele cases contain only meninges, and other 80 to 90% cases involve both meninges and the nerve roots. This is the most serious type of spina bifida. Meningocele involves a sac protruding from the spine but does not contain the spinal cord in the sac. Spina bifida occulta is a mild type of neural tube defect and results in from vertebral arches failing to close. This type of neural tube defect may go unnoticed since it does not typically cause any disabilities. During 3rd and 4th weeks of gestation, about 28 days, the neural tubes close. If the neural tubes fail to close, it results in a form of spina bifida. This can be diagnosed while pregnant or after delivery. During pregnancy, diagnosis can be made from an elevated alpha fetoprotein blood level around, that is 16 to 18 weeks of gestation. Visualization of defect on ultrasound is possible at 18 to 20 weeks of gestation. The sample of amniotic fluid reveals high levels of alpha fetoprotein. Testing has high accuracy, that is 85 to 90%. Folic acid, also called as vitamin B9, neural tube defects is thought to be linked to genetics and environmental factors. There is sufficient evidence demonstrating that low levels of folic acid increases the risk of spina bifida. Therefore, it is recommended for all women who are capable of childbearing to consume 400 micrograms of folic acid daily to help prevent neural tube defects. In 2004, spina bifida cases began to level off despite the use of folic acid. Theories surrounding the leveling include decreased serum folate level secondary to increased obesity rates, low carbohydrate diets, increase in the consumption of whole grain breads, and maternal diabetes. Other risk factors associated with spina bifida include high fever during pregnancy, taking valproic acid or carbamazepine while pregnant for seizure control. Thank you.